Hello and welcome to Noon Conference hosted by MRI Online. Noon Conference connects the global radiology community through free, live educational webinars that are accessible for all and is an opportunity to learn alongside top radiologists from around the world. You can access a recording of today's conference and previous Noon conferences by creating a free MRI Online account. Today, we are honored to welcome Dr. Suresh Mukherji for a lecture entitled Anatomy and Pathology of the Oral Cavity. Dr. Mukherji received his undergraduate degree from Duke University and an MD degree from Georgetown University. He currently holds appointments at multiple institutions and is a devoted educator who's been an invited speaker on over 500 occasions and has written and edited 15 textbooks. He's a consulting editor for both neuroimaging clinics and magnetic resonance clinics of North America and associate editor for the Journal of Computer-Assisted Tomography. We are thrilled he's here today to share his expertise. At the end of the lecture, please join him in a Q&A session where he will try to answer as many questions as we can before our time is up. Please use that Q&A feature to put those questions in. With that, Dr. Mukherji, over to you.
Hey, Ashley, can you hear me okay?
Yes.
Okay, I just need to stop the screen. Let's see, I'll just go and stop the screen sharing. There we go. I sent you an email. I think a couple of people were having a hard time connecting, so maybe that'll just get worked out. I know I received okay, they're on now. Great, fabulous. Yeah, thanks for having me. Again, thanks to MRI Online Modality. It's always a privilege and an honor to be here. Ashley kind of joked and said, we'll take as many questions as you can. I'll take as many questions as they'll allow me to take. I have a free afternoon. I have plenty of time to prepare for this. So if you have any questions, just let me know. And again, thanks a lot to the team, and thanks all of you for joining. I've been working with Modality for, I don't know, 5-6 years, and it's just a terrific team, terrific organization. And so Ashley and the whole team, Jackie and Ben, thanks so much. What I'm going to talk to today is I'm going to talk about anatomy and pathology of the oral cavity. And you'll have to excuse me because I've been traveling a fair amount and I have a bit of a cold. So if I sound a little raspy, that's me. So I'll do my best. And I have my water here as well. But this is a brand new lecture on anatomy and pathology of the oral cavity. And what we decided to do is that we're going to give a 2-part series. And the first part is going to be on the oral cavity, and the second part is going to be on the oral pharynx. And that's going to be held sometime in October. But today we're going to take a real deep drill down into the oral cavity. And the reason why I like this format so much is because, I've been doing this, I hate to say, lecturing since the last century. And what I've seen is that the talks get shorter and shorter and shorter when we go to our annual meetings. And as a result, either we don't get as much time to really teach, or we try, when you go to these meetings, sometimes they're taking 30 to 45 minutes of information and trying to distill it into 15 or 20 minutes. And, part of the challenge now is you're just trying to get through the talk. So what we're going to do over the next 15 minutes or so is really spend a lot of time going over the anatomy. And this is not going to just be focused on cancer. It's going to be focused on the anatomy. And we're also going to give you a differential diagnosis for some of the most common things that we'll see in the oral cavity. So the first thing that we're going to start off with is the anatomy of the oral cavity. So the oral cavity really is comprised of about 7 areas. Now, it really depends on who you read the actual numbers. But in general, we consider the lip, the buccal mucosa, which is basically the undersurface of the lip, the floor of the mouth, the alveolar ridge, the hard palate, the oral cavity, and the retromolar trigone. And we'll go over all these in great detail. The posterior margin of the oral cavity is formed by this papilla here, which is the circumvallate papilla. So everything anterior to the circumvallate papilla is in the oral cavity. The roof of the oral cavity is formed by the hard palate. The inferior portion of the oral cavity is formed by the floor of the mouth. And as I mentioned before, the anterior portion is essentially formed by the lip. Now, these are all illustrations or examples about pathology involving the different subsites of the oral cavity. Again, we'll go through this in great detail, but I did want to emphasize this tumor is located in the buccal region. And I'll tell you why I use the term now, buccal region. The next is in the floor of the mouth. This is an example of the alveolar ridge. This sagittal image is an example of the hard palate. This image is an example of the oral tongue. And this is an area of the retromolar trigone, which is behind the last molar. And again, we'll go over all this in detail, but this is just a snapshot of everything we're going to cover in the next 15 minutes or so. So the first area that we'll talk about is the buccal region. Now, if I was giving a talk on the spaces of the head and neck, then I'll use the term the buccal space. Now, literally just, I've been doing this now for 30 years, but, over the last year or so, I've now sort of changed how I approach this and the terminology that I use. And a lot of it is just the fact that I get to see patients and examine patients once a week in the head and neck oncology clinic. So when we are examining patients, we tend not to use the term buccal space, but rather the surgeons talk about this sulcus right here, which is a gingival-buccal sulcus. So the gingival-buccal sulcus is located right where my arrow is. And then as you go laterally, then we extend into what we call the buccal space. But from a clinical standpoint, the majority of pathology that I see is not necessarily in this true buccal space. Rather, it's in this area, the gingival buccal sulcus. So I'm sort of now referring to this as the buccal region. So the buccal region is formed by this mucosa right here, which is located on the lateral margin of the alveolar ridge and the mandible. And that is the gingiva. So I'm sure all of you know about the gingiva. This is sort of how you brush your teeth. And if you're not brushing your teeth, you're probably getting gingivitis, if you will, with a little bleeding. So make sure you brush your teeth twice a day, right? So that's the gingiva. Now, right lateral to this on the medial surface of the lip is the buccal area or the buccal mucosa. So this buccal area is on the undersurface of the lip. Now, as you know, if you take your finger and you stick it between your cheek and your gum, you can go ahead and do that if you want to. I'm not going to look. I'm not going to have you turn on your cameras. But if you press it all the way down to the deep area, where you stop, basically where the gingiva and the buccal area meet, is referred to as the gingival buccal sulcus. And these are the common areas for tumors to involve this buccal area. So one of the misnomers that I've done in the past is that we talk about buccal space or buccal region cancers, and we talk about buccal squamous cell carcinomas. So as you'll see in the slides that are coming up, these squamous cell carcinomas tend to occur in this gingival buccal region or the gingival buccal sulcus, and then these other pathologies arise in the buccal space. So we talked about this anatomy, which is the gingival buccal sulcus, but the other piece of anatomy in the buccal space is, for instance, this muscle right here, which is the buccinator muscle. And this extends posteriorly into an area of the pterygomandibular raphe, and we'll talk about that later. As we extend out laterally, now we get into the subcutaneous fat. This little vessel right here is the facial vein. And then we have this swooping structure that is contiguous with the parotid gland that pierces the buccinator muscle and extends into the gingival buccal sulcus at approximately the level of the second molar, and this is the parotid duct. Now, if you look at the buccal space, there's this superficial buccal fat and this deep buccal fat, and that demarcation is essentially provided by where this parotid duct is located. If you look a little bit more laterally, and it's hard to see, but you can have these small superficial muscles of facial expression. And just lateral to this are going to be branches of the buccal division of the facial nerve. Now, we can't always see these normally, but on the other hand, if we do have perineural spread along these buccal divisions, we can sometimes see those striations. So this is what I call the buccal region. One more example here. This is a tumor involving the gingival buccal sulcus. And just lateral to this will be the fat involving the buccal space. So I spent a lot of time on that. But on the other hand, especially if you're in an area such as in India or in other areas, I know my colleague Varsha is on the talk right now. In India, they have a lot of betel nut. In the US, we have some snuff dippers. That's where the majority of those cancers are going to be. So this is just an example here of a squamous cell carcinoma involving the buccal region, involving the gingival buccal sulcus. As I mentioned before, I'm from India. There's a lot of betel nut usage. So they stick the betel nut and they put it between their cheek and their gum. And the United States, where I grew up in the South, we have a lot of snuff dippers. So in order to get your nicotine fix, you take this snuff and you put it right literally between your cheek and your gum. And as a result, these areas are prone to develop squamous cell carcinoma, which is going to be the most common tumor to involve this buccal region. Now, one of the challenges, and as I mentioned before, Wednesdays I see patients, is that we had a couple patients yesterday that had tumors involving the gingival buccal sulcus. Now, the challenge is if you see something like this on imaging, you don't really know whether it's actually going to involve the buccal area, which is the undersurface of the lip, or if it's actually going to involve the gingiva, which is overlying the maxilla and the mandible. So if we're just looking like this, we have to be somewhat nonspecific. We can describe the tumor and we can describe, if you will, this lateral extent, but we really don't know where it's located. And this is where that puff cheek technique comes into play. So here's another example of a buccal squamous cell carcinoma. Again, we can describe this and we can measure the size of it, but we don't really know specifically where it is. Now, here's an example of the classic puff cheek technique. So what you can do if I know as radiologists, you can't literally monitor every patient that's there, but if you can train your technologists to say if they do have these cancers involving, if you will, the lip, just go ahead and have the patients puff their cheeks. And all of a sudden, we can see this nice squamous cell carcinoma. But it's not nice, but this squamous cell carcinoma that's really isolated to the lip. And if you look real closely, we can see this reticulation of fat extending laterally. And compare this with the opposite side. Notice the nice mucosa here involving the lip and the nice fat plate on the left-hand side. Another example here, another example of a carcinoma involving the buccal area. This is involving the buccal surface of the lip and also the lip itself. So we'll just go ahead and call this the buccal region, but this is a true lip carcinoma that's separate from the gingiva. So you can remember that buccal area. Now the challenge is also is that these buccal cancers are in a close approximation to the lip and also the teeth. Now, I don't know about you, but as a kid, I used to eat a lot of hard candy, and some of you may have that as well too. But one of the challenges is that if you have a lot of amalgam involving your teeth, if you have a lot of teeth fillings where they've used this with the metal or the silver, you can occasionally have this streak artifact. So one of the pitfalls that we get into as a radiologist is that a patient will present with a cancer involving the gingival buccal area. And if you read this, you'll just say, I don't see any tumor at all. But there actually is a tumor because you can look, the surgeons can look in and actually see the cancer. So one of the pitfalls that we run into about tumors involving the gingival buccal region is that they can be obscured by this spray artifact. So this is that same patient that had a PET CT, and on the PET CT, we can nicely see this cancer that has abnormal FDG uptake located in the gingival buccal sulcus. So, I caution you about something like this because if you say it's normal and they see the cancer, it kind of reduces our credibility. I think it's fair to say that this area is obscured by streak artifact, and then it's really best to be evaluated clinically. So just a little modification in how you report this, I think, can increase your credibility to your referring physicians. Another example here, this is the second most likely tumor to involve the buccal region, and this happens to be lymphoma. So number one is squamous cell carcinoma, and the second most likely tumor to involve the buccal region is going to be lymphoma. So here's an example of a nice lymphoma that's involving the buccal region. This is the buccal cortex of the maxilla, and here we can see this intermediate signal mass that's involving the soft tissues. Now, it's rare for lymphomas to actually arise in the buccal area itself. Oftentimes, they may be secondary extension. This example was a lymphoma that involves the right maxillary sinus that blew through the maxillary sinus through the alveolar recess and is involving the buccal area. Now you look at this and you'll say, well, it sort of looks like the sinuses, but what I want you to remember is draw a line down the middle, compare one side to the other side. So when we're at this level, what we see here is the masseter muscle. This is a nice example of the deep buccal space. And at this level, we really don't see any air involving the alveolar recess of the maxillary sinus. So when you look at this, you can see that all of this is not the maxillary sinus, but this is all lymphoma that's involving the left buccal space. Now, when we talk about the buccal region, the other common lesions that can involve this area include things such as minor salivary gland tumors and mesenchymal tumors. So what I want to do is first talk about the mesenchymal tumor. So this was a patient, a younger patient, it was about a 30-year-old patient that we ended up seeing in our head and neck clinic. I remember this. When we looked at him clinically, it looked like a relatively small tumor that was involving the lip. So we were able to identify it to involve the lip. And if we look laterally, we can see all this obliteration of the fat. So this was clinically unknown. So we have to remember that I'll mention this extent and also the proximity to the parotid duct. But my point in this particular case is that when we talk about differential diagnosis of the buccal area, we tend to, it's head and neck, so we tend to get nervous, and because it's head and neck, it's supposed to be really complicated. The point that I want to make is that just realize in the head and neck, the component tissues of the head and neck are the same that we see everywhere else in the body. So if you remember, I talked about this structure right here was the buccinator muscle. That's muscle. We talked about this area here, which is fat. That's fat. Fat's seen everywhere in the body, and we have skin. So the majority of tumors that we're going to see in the head and neck arise from the component tissues, and these component tissues are seen everywhere else in the body. So the number one thing is going to be squamous cell carcinoma. The second thing is going to be lymphoma. And the third thing is oftentimes these little sarcomas and these mesenchymal tumors can be seen anywhere. So just remember when you are looking at differential diagnostic considerations in the buccal space, remember you have muscle and fat. And if I showed you this for a leg, I'm sure you could easily come up with a diagnosis of a sarcoma. But just realize sarcomas arise in the head and neck area as well, too. Now, one of the things that's kind of unique about the head and neck is that we can have these minor salivary gland tumors. So it took me about 25 years to really understand this. Like I said, I'm not the sharpest tool in the shed, but eventually I kind of get it. What is a minor salivary gland tumor? Well, we know that they're salivary gland tumors. And we have salivary gland structures, which include the parotid, the submandibular gland, and the sublingual gland. If you have salivary tissue in the major glands, well, that is salivary tissue in a big gland. But on the other hand, what happens in the head and neck is that you can have ectopic rests of salivary tissues that get lost, if you will, and they end up in areas where in general they shouldn't be. Now, certain areas do have a predilection, and one of these areas are in the buccal space. So you can end up having the exact same type of tumors that you can have in the parotid gland or the submandibular gland because that salivary tissue is there. But if that salivary tissue is somewhere where it shouldn't be, so you have a tumor arising in salivary tissue that's not in a major gland, that's what we call a minor salivary gland tumor. And in the buccal area, there is a higher concentration that we expect there to be. So this is going to be one of those weird head and neck pathologies. And so we have to include minor salivary gland tumors when we see masses involving the buccal space. And in this case, it was a mucoepidermoid carcinoma. The other things that can arise here include adenoid cystic carcinoma. We can have pleomorphic adenomas arise here as well, too. So those are the minor salivary gland tumors that we have to consider involving the buccal space. The other thing in the buccal space, and this is more rare, but if you really love head and neck cancers, you have certain lymph nodes that are involving face. Now, this is a specific type of lymph node that are called facial lymph nodes. I won't get into too much detail, but I did want you to know there are about 5 types of facial lymph nodes. And this is an example of a buccal lymph node located in the buccal space. Again, the involvement is pretty rare. In general, when we reported and described these lymph nodes about 30 years ago, they were mostly involved with recurrent squamous cell carcinoma, lymphoma, and recurrent melanoma. But this is the classical example. In fact, with a leap of faith, it almost looks rounded, and it's located in the buccal space. So that's a buccal space lymph node. So we talked a little bit about tumors involving the buccal region. Now what we're going to do is talk about some other pathology involving the buccal region, and we'll specifically talk about infection. Now, I have the privilege of working with some terrific head and neck surgeons and also some terrific dental pathologists. And I also have a joint appointment in the oral maxillofacial radiologist. And it's amazing. These wonderful people know so much about the teeth. It just makes me feel so inadequate. So I just know a small amount. But what I'll do is I'll just mention about how odontogenic processes can lead to various infections in the region of the oral cavity. So if we look at a patient that presents such as this, what we see here is all of this reticulation involving the fat. It's all involving the buccal space. In fact, if you look real closely, we can see a small little subperiosteal abscess. Well, the take-home message is the following: is anytime that you have an unexplained infection involving the buccal region and the cheek, the first thing that we have to exclude is a bug bite. Make sure they didn't have impetigo or there was something that they had a bite or something like that. But if that's been excluded, just realize that odontogenic processes and infections that involve the teeth, if they breach the buccal cortex, they can extend into the soft tissues of the face. So this is an example of a small little odontogenic infection that eroded the buccal cortex. And when it erodes the buccal cortex, it extends into the soft tissues of the face. So buccal space infections, bottom line is, they can arise from infections involving odontogenic infections. Here's an example of a lymphatic malformation involving the buccal space. Again, very, very nicely identifying the buccal space. We can see involvement of the superficial and the deep lobe. Again, classical appearance of a lymphatic malformation. It's high signal on T2, low signal on T1, and is not enhanced with contrast. In fact, if you look at this, it's not fully low signal. The slightly high signal is probably due to some proteinaceous material in the lymphatic malformation. But again, the point of this case is to identify the proper location of the buccal space. Now, you can also have some other areas that involves the buccal region and the buccal space. I was looking at this one case here, no history whatsoever, and I just happened to see this little area of increased attenuation. This is just a foreign body that's located in the buccal space. I never had the opportunity to figure out what it was due to. You know, it could be due to, I guess, a rock if he was hurt in the past, or maybe a BB or something like that. But we can see that it's located in the fat in the buccal space. And these are always kind of fun. We see these a lot on sinus ETs. I remember the first time I saw this, I was kind of taken for a loop. I saw this oval structure, and really all this was what we lovingly referred to as a comestible, which is basically a piece of candy or something like that. I think this was a jawbreaker, if you know what that is. So this was just a piece of candy that was located in the gingiva buccal sulcus. I think this patient came back later, about a year, and it wasn't there. So obviously it dissolved over the year time. But again, nicely demonstrating the location of the buccal region. So what we did first is we talked a fair amount involving the buccal region. We talked about the gingiva buccal sulcus, which is where the majority of squamous cell carcinomas occur from. And we talked about the buccal space. And we gave a differential diagnosis for buccal space lesions, in which we also have to include lymphoma and minor salivary gland tumors. Now what we'll do is move on to the oral or the mobile tongue. So when we look at the tongue, there's actually two parts to the tongue, and that's separated by this area right here, which is a circumvallate papilla. So everything posterior to the circumvallate papilla is located in the tongue base, and then we'll talk about that when we talk about the oral pharynx. But everything anterior to the circumvallate papilla is located in the oral tongue, and it's also known as the mobile tongue. So when we look at the innervation of the oral tongue, it actually has a very unique innervation. Part of the oral tongue is supplied by the lingual nerve, which is a sensory branch of the fifth nerve. We also have taste involving the anterior two-thirds of the tongue, and the motor portion of the oral tongue is supplied by the 12th nerve. So just in the oral tongue, you have three different nerves providing innervation. 12 is motor, 5 is sensory to the anterior two-thirds, and then the chorda tympani is the taste. And I think all of you hopefully will remember that from medical school. So what's the most common tumor to involve the oral tongue? Well, it's going to be squamous cell carcinoma. So again, this is not purely a talk on cancer, but I just did want to point this out that this is going to be the most common tumor to involve the oral tongue. Now, one point that I did want to make is that when we are looking at oral tongue carcinomas, realize that it's good for us to make a measurement on the largest size of that tumor. And the reason is that this helps us with staging. But the new 8th edition of the AJCC is not purely based on size alone, but there is something called the depth of invasion. So what the depth of invasion is that it is a pathologic diagnosis. When you are measuring an oral tongue cancer like this, it is a good idea to try to make the largest measurements because when the surgeons look at this, they're trying to figure out how large it is. What ends up happening on radiology, on imaging, is that we can look in various sections. We can look in axial, coronal, and sagittal sections. And when we look orthogonally, we can actually measure this a lateral or horizontal measurement. This horizontal measurement is tumor thickness. It is not depth of invasion. Depth of invasion is a pathologic measurement where the pathologist looks at the basement membrane, and what they do is they basically approximate the location of the basement membrane, and then they look deep to it. And what they're looking for is how deep do these tumor cells go with relationship to the basement membrane. So this is the basement membrane. Excuse me, this is what we mean by depth of invasion. The challenge is the worse prognosis of depth of invasion, the deeper it is, the higher likelihood there is of microscopic evidence of perineural invasion, not perineural spread, but perineural invasion, and also lymphatic invasion. Also, the deeper the depth of invasion is, the higher likelihood there is of metastases to lymph nodes. So realize this is a histologic, pathologic measurement, and tumor thickness is not the same as depth of invasion. Now, this is just the overall classification. When you look at this, T1 is less than 2, and T3 is greater than 4. But once you get to levels of T2 and portions of T3, this is a combination of size and the depth of invasion, with the depth of invasion really being the driver. The more depth of invasion is, this tends to push the staging higher. And again, that's a new addition to the 8th edition. But again, please, tumor thickness is not the same as depth of invasion. So when we are evaluating the oral tongue, really the best way to look at the oral tongue is to perform MR. So in the United States, we don't do as much MR as they do in other parts of the world, specifically in Europe, some parts of India and some parts of Asia, and probably South America as well too. You know, why that's the case, it's probably multifactorial. But I think part of it is in the US in general, patients end up getting a PET CT. So they're getting a CT and they're getting a PET. Now, personally, I think you should do the CT separate from the PET. But, you know, depending on where you are, and we also have to take into factors regarding payment for the patient, because in the US, you know, we have co-payments, patients' insurers differ. So we always have to factor that in order to make sure we have some level of healthcare equity and try to reduce our disparities. But on the other hand, if you're in a place where money is not necessarily an issue, and let's say you have a more of an egalitarian approach to your healthcare and how you acquire imaging, I think MR probably is the best way to look at the oral tongue. But you have to make sure that you hold rock solid still. So this is an example of a patient that has an oral tongue cancer, and it's really, really hard to see the tumor. But on the other hand, when you perform the MR right here, you can see this small little tumor that's involving the lateral aspect of the oral tongue that you cannot see on CT. So again, a nice example of a tumor that's better seen on MR than compared to CT. Another example here, this patient has a low volume cancer involving the oral tongue. Again, you can't see it because of the streak artifact. Again, I caution you, if you're looking at the CT, not to call it normal. What you can say is that the tumor is not seen on the CT and can be evaluated with direct visualization and palpation. You can also suggest that there's no deep invasion, which is the surgeons are looking for, because typically they can see the cancer on the oral tongue. But I would caution you not to say it's normal, because when you look at the PET component on this PET CT, we can see a lot of abnormal FDG uptake. So again, as we talked about when we talked about the gingival buccal area, just realize we're going to run into the same artifacts when we're evaluating the oral tongue as well. Now, here's an example of a patient that has a congenital malformation involving the oral tongue. This is a teratoma. So how do we know that this is a teratoma? How do we make the diagnosis? Well, if we see calcifications and if we see fat plus calcification equals teratoma. And this was an example here of this oral teratoma. And this arrow right here actually looks at the calcification that we're seeing on MR that we're actually seeing much easier on CT. So this is just an example of an unusual form of a teratoma. Now, some patients will present with macroglossia. So again, we can't, unless you're actually examining the patients, you may not see this, but clinically, the patients will present with macroglossia. Now, this is an example of macroglossia that's due to edema. This edema can be due to a variety of things. Now, one thing that I have learned over time, if I have someone that comes in with the unexplained edema, the first thing in my mind is I want to make sure they haven't had an anaphylactic reaction. So it would be a little bit unusual to have an anaphylactic reaction in a patient that already has macroglossia. So, but on the other hand, if you are doing a CT scan and you see edema, the first thing you have to make sure they haven't reacted to the contrast. But on the other hand, if I see a patient that's 40 or 50 years old and I see unexplained edema, especially involving the tongue, or sometimes I'll see it in the retropharyngeal space, I want to make sure they don't have calcific tendinitis to give the edema involving the retropharyngeal space. But on the other hand, I also want to make sure that they're not on some type of ACE inhibitors. Because remember, these ACE inhibitors, one of the side effects can be edema. So there are a couple of cases that we've actually suggested the possibility that the edema is due to an ACE inhibitor due to the antihypertensive. So it's one of these things that I would recommend you keep in the back of your mind. This is an example of a patient that had a large macroglossia, and this was due to amyloid infiltration. And this was an example of macroglossia that was due to a large vascular malformation. And we can see this is a low flow vascular malformation, and this was due to diffuse enhancement involving the tongue. So when we look at the oral tongue, one of the quote unquote pseudo lesions is what we're illustrating here. So this is a non-contrast T1 weighted image. So on first glance, when you look at this, you think, is there an enhancing mass involving the right half of the tongue? Well, you always have to check yourself and say, well, this is a non-contrast T1 weighted image. Then you have to think yourself, is it possible this could be hemorrhage? But when you take a closer look, notice how this abnormality is basically dead midline. It's basically involving the right half of the tongue, and it's high signal on T1. So this is a nice example of long-standing denervation atrophy involving the oral tongue. So when you see something like this, what you want to do is remember, as we talked earlier, the motor innervation of the tongue comes from the 12th nerve. Now, this 12th nerve has multiple components to it. It eventually passes through the hypoglossal canal right below the famous eagle's beak. So if you look at this, we can see the neck of the eagle, we can see the head of the eagle, and we can see the beak. So that's where the 12th nerve passes. So if you see something like this, you want to pay close attention to the basi-occiput. And in this particular case, the white arrow shows the normal appearance of the eagle's head and the beak. And there is the 12th nerve right at the neck. And on the right side, we can see an aggressive enhancing mass that's eroding the basi-occiput and involving the 12th nerve. So this aggressive mass resulted in this 12th nerve palsy. So the next area that we'll talk about is the floor of the mouth. Now, I'm giving a talk on the oral cavity, so I'll use the terminology floor of mouth. But on the other hand, if I was giving a talk on the spaces, I would use the term the sublingual space. So pure and simply, the sublingual space is that area that's below the tongue. Now, I think Varsha mentioned this in her talk recently, is that she remembers how I taught her. The sublingual space is pure and simply, you stick your tongue out, you put your finger under your mouth, under your tongue, and you press down. So everything below your tongue is located in the floor of the mouth. So when you look at the floor of the mouth, the components are the lateral aspect of the mandible, and we see this little myeloid line right here. There's a muscle that goes from the myeloid line to the hyoid bone. This is called the mylohyoid muscle. That's how it gets its name. Now, if you look medial to it, we have this gland right here. This is the sublingual gland. Just medial to this, we have the submandibular duct. This is also known as Wharton's duct. So even though the submandibular gland is down here in the submandibular space, we'll see in a couple of slides that duct actually crosses into the sublingual space. Below this is a nerve, that's the lingual nerve. Below this are one of the many veins involving the floor of the mouth, and right below this is going to be the hypoglossal nerve. Then we have a muscle that goes from the hyoid bone to the tongue. This is the hyoglossus muscle, and just medial to that is the lingual artery. So when you look at the sublingual space, we refer to this muscle as the mylohyoid sling. So when I look at something like this and then I see the mandible, that kind of looks like a teacup to me. So the way that I remember the floor of the mouth is that I see the rim of the mandible right here, which forms the rim of the teacup. The sling right here is a mylohyoid muscle. There's one on both sides, so that forms the wall of the teacup. And then the base of the teacup is formed by the hyoid bone. So basically, all of these contents that we talked to are located in the cup. And what would be over the cup? Well, that would be the tongue. So that's how I remember the sublingual space. So when we look at the sublingual space, the most common tumor to involve the sublingual space is going to be squamous cell carcinoma of the floor of the mouth. So here's an example of squamous cell carcinoma of the floor of the mouth. Now, how do we know that we're in the sublingual space? Well, the way you look at it is that you look at these muscles right here. These muscles right here are the genioglossus and geniohyoid complex. At this specific level, they go from the genial tubercle back to these transverse muscles, which are the tongue base. So what do you call this that goes from the genial tubercle back to the tongue base? Remember, lingua is Latin for tongue, but glossus is Greek for tongue. So when we actually talk about these muscles that go from the genial tubercle to the tongue base, we use the Greek root, and that is genioglossus muscles. So the way that we know we're in the floor of the mouth is you look for these vertically oriented muscles, and all of a sudden when they disappear and these intrinsic muscles, which are more transverse, that's how we know we're at the tongue base. So this tumor right here is located in the left floor of the mouth. Now, these are other examples that can involve the floor of the mouth. Again, I'm going to start with the one on the right. Again, components of the floor of the mouth are things like muscle, they're things like fat, so on and so forth. So this was a patient that presented years ago with an enlarging tongue, and this happened to be a liposarcoma. We can see the large fatty lesion here. We can see a soft tissue component. And again, this is a mesenchymal tumor. So when you are looking at floor mouth cancers, remember any tumor that can involve any of these components that we talked about can result in tumors. And remember, these components are everywhere in the body. Now, this is an example of one of the weird head and neck ones. This happens to be a minor salivary gland tumor. Again, in the head and neck, you can have those minor salivary gland rests. But remember, in the floor of the mouth, we actually have the sublingual gland. So this can actually be a major salivary gland tumor. Why? Because they can actually arise from the sublingual gland. So we have to include minor salivary gland tumors. In fact, minor salivary gland tumors are the second most likely tumor to involve the floor of the mouth behind squamous cell carcinoma. Why? Because we have the sublingual gland located in the floor of the mouth. Now, this was another example of a tumor that can involve the floor of the mouth. So we talked about squamous cell carcinoma, we talked about minor salivary gland tumors, we talked about mesenchymal tumors. But remember, when we talked about the floor of the mouth, we also talked about nerves. So we have to remember nerves also have tumors. So how can we suggest the diagnosis that this was due to a neurogenic tumor? Well, remember, these nerves are located just medial to the mylohyoid muscle, and then lateral to the genioglossus geniohyoid complex, and just lateral to the mylohyoid muscle. So this was a mass right here, well-defined mass that's located in the floor of the mouth. When I see something like this, again, squamous cell is going to be number one, minor salivary gland is going to be number two, but when I see something like this so well-defined, I'm going to suggest the possibility of a schwannoma. Now, I thought this was going to be a schwannoma, but the biopsy came back neuroma. I don't know how they got a neuroma. Neuromas are typically post-traumatic, but I asked a couple of times, and the pathologist was sure that this was a neuroma involving the floor of the mouth. Now, when we talk about floor mouth abnormalities, again, remember the submandibular gland has this duct that runs in the floor of the mouth, and eventually it empties out right here at the frenulum. So in your practice, oftentimes patients present with a left-sided neck mass. Sometimes they're lipomas, but sometimes they're actually an enlarged submandibular gland. Remember, the insertion of the submandibular duct is at the hilum of the submandibular gland. Then it crosses over the free margin of the mylohyoid muscle and inserts at the frenulum. And this was an example of a sialolith right here that obstructed the submandibular duct, resulting in an obstructive sialadenitis involving the submandibular gland. You can also have abscesses involving the floor of the mouth. If you have a mass like this, remember the odontogenic processes. If it erodes the lingual cortex like this and extends into the floor of the mouth, we can have an abscess involving the floor of the mouth. Always remember to look at the bone algorithms, because if you see this, here we see the rotten tooth. Here's odontogenic disease. This is a little dental caries right here. And this was the origin of this left floor mouth abscess. So earlier we talked about these infections going laterally into the buccal space. In this case, if they extend medially, then this is how you get a floor mouth abscess. If it becomes really bad, we can go on to have Ludwig's angina. This is really a clinical diagnosis first described by Wilhelm Friedrich von Ludwig back around the turn of the century. And this is an example of Ludwig's angina, which was all cellulitis. This is a choking sensation from an infection, but this is an example of what we more typically associate with Ludwig's angina. Multiple abscesses extending along the compartments of the floor of the mouth, essentially resulting in compartment syndrome. This can extend into the airway. It can give you laryngeal edema, and this gives you the strangulation. And these are patients that had Ludwig's angina due to cellulitis. This one had the abscess, and this patient had to have all of these abscesses drained. You can also have developmental lesions involving the floor of the mouth. If it's anterior and midline, these are epidermoids. So here it is, high fluid collection, high signal on T2 and on CT. This is due to small little areas of ectopic ectoderm getting caught in the midline plates as your mouth develops. But on the other hand, if you have a cystic lesion involving the lateral aspect of the floor of the mouth that is contiguous with the sublingual gland, then we have to think of a frog and we have to think of ranulas. So this is an example, another example of a ranula. They're paramidline, they're fluid collection, and they're felt to be some type of obstruction or malformation. Some people even say mucocele. I don't like that term, but some people will use that of the sublingual gland. If they can extend inferiorly through the mylohyoid muscle, oftentimes there's a little defect in the floor of the mouth. Notice the normal mylohyoid muscle on the right, there's a defect on the left. And if there is a defect, these ranulas can extend inferiorly through the submandibular space, through what we call a boutonniere deformity. And this is what's referred to as a complex ranula. So if it's in the floor of the mouth, it's simple, if you will. But if it extends into the submandibular space through a defect, we can call this either a diving, a plunging, or a complex ranula. Another example here, this was an example of a floor mouth arteriovenous malformation. These oftentimes I've seen them arise in younger women, especially in pregnancy, because they either the hormonal changes or the higher blood volume. Both of these patients were in younger patients that were both pregnant, and oftentimes they'll actually present with rapid bleeding because of that elevated blood volume. So oftentimes they'll be quiescent, but when you do have these changes, all of a sudden they can present with rapid bleeding. Well, the last two areas that we'll talk about are, first of all, going to be the retromolar trigone. So what is the retromolar trigone? Well, the retromolar trigone is that area that's behind the last molar. So you have the central incisor, lateral incisor, canine, first premolar, second premolar, first molar, second molar, third molar. And this triangular space behind the third molar is referred to as the retromolar trigone. Now, for those of you that have had your wisdom teeth resected, congratulations, you have the largest retromolar trigones on this seminar. So you are the best at something. I know I've always wanted to be the best at something. I've never quite accomplished that, but I still have my wisdom teeth, so I didn't make the cut on this. But if you look, we talked about this earlier, here's the buccinator muscle, here's the superior constrictor muscle, and right here is the pterygomandibular raphe. So the implied anatomy behind the retromolar trigone is that this pterygomandibular raphe is here. And on the sagittal images from Elsevier, we can see this location of the retromolar trigone. The other applied anatomy is the proximity of the anterior portion of the mandible to the retromolar trigone. This complex anatomy is super important for retromolar trigones. So first of all, there's an example here of a retromolar trigone carcinoma. They can extend laterally, they can extend posteriorly, anteriorly, and directly posterolaterally. So the point about retromolar trigone carcinomas is that if you take a 4-centimeter tumor and you stick it in the oral tongue, well, it's just going to grow in the tongue. But on the other hand, if you stick a 4-centimeter tumor here, it can extend anteriorly, posteriorly, it can extend anteriorly here and erode the back of the mandible, and it can extend posteriorly and erode the anterior cortex of the mandible. These are really, really important spread patterns that you just can't see clinically. We had a patient yesterday that had a retromolar trigone, and the surgeons had no idea that it had eroded the bone or extended anteriorly. So this is where we really, really make a difference. So here's an example of a retromolar trigone carcinoma. Now, I put a little tiger here. I'm from Bengal, India, and these are my famous tiger stripes. I love my tiger stripes. So if I draw a line down the middle, compare the right side to the left side, what I see here is I see mucosa right here involving the lip. Then I see fat. Then I see, again, gray right here, which is the outer portion of the lip, and then I see fat. So these are my normal tiger stripes. But on the right-hand side, notice my tiger stripes are gone. And what I see is this large mass that has a comma-shaped appearance involving the retromolar trigone. So that's the full extent of this. Now, because these tumors can grow superiorly along the pterygomandibular raphe, it's always important to look all the way up to the hook of the hamulus. So here's the pterygomandibular raphe, and here's the hook of the hamulus. So on the left-hand side, here's the hook of the hamulus, and here are my normal tiger stripes. See the black? See the gray right here? See this right here? On the opposite side, here's the hook of the hamulus, and notice my stripes are gone. This is all blurry. This is very subtle superior extension of this retromolar trigone carcinoma all the way up to the hook of the hamulus. And the reason why I emphasize this so much is that I think part of the reason these tumors do so poorly is that they're understaged and underappreciated on clinical examination. Another example here, here's a retromolar trigone carcinoma. Clinically, they thought they could get this out. But on the other hand, if you look closely, there's actually bone erosion here involving the anterior aspect of the mandible. That was not detected on clinical imaging. Rather, the surgeons looked in the mouth and they saw this component, but they didn't appreciate this deep component. And again, look at my tiger stripes. See how the tiger stripes are obliterated. And one more example, this was a patient that the surgeon thought that they could get out doing a partial mandibulectomy. But on the preoperative imaging, what they didn't appreciate was the replacement of the signal within the mandible. And when we gave contrast, all of this was enhancing right here. So the surgeons ended up doing a partial mandibulectomy. They didn't get enough and came back with a positive margin. So I strongly recommend retromolar trigone carcinomas to undergo CT and contrast-enhanced MR because the CT is going to be better for the early cortical invasion. The MR is going to be better to look for all the involvement of the marrow. So it truly is complementary. So the last couple of things about the retromolar trigone is that you can have infections involve the retromolar trigone, and they're typically from, again, odontogenic infections involving the alveolar ridge. So if you have a maxillary molar tooth that becomes infected, you can end up having a little abscess here. And again, compare my tiger stripes. Look at the left side. See the nice stripes right here? Again, there's the abscess right here. Another example here, this is not abscess, but a big phlegmon involving the medial rectus muscle. Notice, excuse me, the medial pterygoid muscle. Notice the medial pterygoid muscle on the left. Notice how it's all inflamed on right. Again, this was all due to odontogenic disease. If the infection extends laterally, you can end up having myositis involving the masseter muscles. Again, this was a wisdom tooth that was resected. Unfortunately, the patient developed an infection and developed bilateral myositis involving the masseter muscles. Again, all due to odontogenic infections in the retromolar trigone. And this was an example of medication-related osteonecrosis. If we look at the bone right here, we can see the bone-in-bone appearance. You could see this following radiation therapy, but if you have patients that somehow have jaw pain, especially in elderly females that are on some type of calcium replacement medications, always consider the possibility of medication-related osteonecrosis. And the last thing that we'll talk about is the hard palate. So when we talk about the hard palate, it's very, very interesting because it has numerous components to it and a lot of important applied anatomy. So when we look at the palate, we have these two plates right here, which are the palatal process of the maxilla. Then when we look more posteriorly, we have the flattened component here of the palatine bone. Remember, the palate has its own bone. It's actually shaped as an L. It has a vertical component, which would basically go into the screen, but this flat component right here forms that hard palate. It also has a few foramen. We have the incisive foramen here. We have this little foramen, which is the greater palatine foramen, and then we have a lesser palatine foramen, which is located here. So this is just an example of a large incisive canal cyst. I saw this case probably about 2 months ago. This patient presented with really bad breath, apparently. So this would have intermittent drainage. And when we looked at this, this was the largest incisive canal cyst I'd ever seen. We can actually see it here pushing into the inferior portion of the nasal cavity. And we can see the submucosal mass here it presented with the hard palate, but this was all due to an incisive canal cyst. Now, the most common tumor to involve the hard palate is going to be squamous cell carcinoma. Again, squamous cell carcinoma is going to be number one. And in general, you can look right in there and see that big squamous cell carcinoma. But remember, we talked about that applied anatomy. So if I go back to this slide, we can have these greater and lesser palatine foramen. These squamous cell carcinomas can extend posteriorly. Here's the normal greater palatine foramen on the left. And notice the palatine foramen on the right is enlarged, eroded, and expanded. And this is actually retrograde perineural spread of squamous cell carcinoma. When we are evaluating these tumors, we also want to look at the bone because if this tumor is just limited to the mucosa, then they can do a wide local excision. But if we say there's potential perineural spread or if there is bone erosion such as this, then the patients have to end up going some type of maxillectomy. And I can tell you, yesterday in clinic, again, it was a crazy day in clinic. We had a patient that came in with a minor salivary gland tumor that they thought was a superficial lesion, but there actually was perineural spread along that greater foramen. So I haven't gotten the slides yet, but the next time I give this, I'll be sure to show it because it was kind of a crazy case. So number one is going to be squamous cell carcinoma. The second one is going to be minor salivary gland tumors. When we look at the hard palate, there is, again, a higher density or proportion of minor salivary gland tissue in the hard palate. So this has a propensity for the hard palate, the soft palate, the buccal space, and also the tongue base. So when we are looking at tumors involving the hard palate, number one is squamous cell carcinoma, and number two are going to be minor salivary gland tumors. How can we tell the difference? Well, it's really, really hard to tell. I think if we see something that has high T2 signal and is well defined, we can suggest that it's a benign lesion like a pleomorphic adenoma. But again, it's really up to pathology. When we see something like this, then we have to consider squamous cell carcinoma or mucoepidermoid carcinoma. And again, if you look real closely, notice this enlargement right here of the greater palatine foramen on the left compared to the one on the right. So again, anytime that you see these tumors extending laterally, we have to take a close look to make sure we don't have that perineural invasion, because that makes all the difference in the world. And the last thing that I'll end on is that once these tumors end up growing along the greater or lesser palatine nerve, they can go here into my favorite foramen. So this foramen is located between the pterygoid plates and the palatine bone, and that's the pterygopalatine fossa. So this is an example of a tumor that's located in the left pterygopalatine fossa. So the normal anatomy here is sphenopalatine foramen, pterygopalatine fossa. Once they get into this fossa, they can jump on V2. This is the second division of the fifth cranial nerve. Here we see on the coronal images, we can see abnormal enhancement of V2 on the left. On the right side, you can actually see the nerve surrounded by the vascular plexus. And if you have a really sharp eye, you can actually see abnormal enhancement involving Vidian's nerve on the left compared to the right. See that right there? There it is right there. And on the axial images, we can actually see the tumor. So the reason why this is important is that these tumors can jump on V2 and go all the way back into Meckel's cave. So here's Meckel's cave on the right-hand side, the normal appearance, and here it is on the left. So when you see something like this has made all the difference in the world over the last 30 years. When I was most of your all's age, because I assume all of you are younger than me, our referring physicians didn't believe that we as radiologists could actually identify perineural spread. And we would tell them, but they would go in and operate. Now, if we as a radiologist say there's actually perineural spread, they listen to us. And in fact, if we say there's perineural spread back into Meckel's cave, especially in patients with squamous cell carcinomas or minor salivary gland tumors involving the palate or the maxillary sinus, oftentimes these patients are going to be treated with non-surgical organ preservation therapy and not be treated with surgery. So one of the joys that I have in head and neck radiology is I've seen a complete transition over the last 30 years, and it just emphasizes to me the important role that we play in taking care of our patients. So in summary, what we did over the last 55 minutes or so is that we talked about the different subsites of the oral cavity. I tried to give you a differential diagnosis of the most common things that you'll see at each one of these sites. And my hope is that over time, you'll really appreciate to learn the anatomy of the head and neck. And for me, I can't think of another job I'd rather do than to be a head and neck radiologist. So thank you very much for your attention, and I'm happy to answer any questions.
Thank you so much for that awesome lecture, Dr. Mukherji. Yeah, at this time, we're going to open up the floor to questions. So if you've got those, put those into that Q&A feature so we can get through as many as we can. And I'm not sure if you can open up that box, the Q&A
Yeah.
box, Dr.
Are
Mukherji.
we doing chat or are we doing
Go,
questions?
yeah, the Q&A bubble, that box. If you pop that
Yeah.
open, you got a
I see
bunch
the
in there.
webinar chat. I don't see the Q. Where's the Q&A chat? Let's see.
Okay, it
Did
might
you see the
be.
chat?
They're coming through the bubble. If you want to hover your mouse on the top of your screen, you might
Okay, I
see
got
it.
it now. I think I got
Amazing.
webinar chat. Okay, great. Okay. All right. Want me to start at the top?
Yeah, perfect.
Okay, great. Okay, let's see. I'm gonna go down there without jumping over the questions. So the radiological features of the hard palate. So I just like I confused you there, so I don't want to confuse you there. So the hard palate on the sagittal images, this is going to be the hard palate that's located here. So when we talk about the hard palate, it's probably one of the most easier areas to see because this is the sagittal image right here looking at the hard palate. The hard palate has really two primary components to it, like I mentioned before. We have these palatine processes of the maxillary bone, and then we have this portion right here, which is the vertical or the horizontal plate of the palate. So these are all the components of the hard palate. We have the incisive canal here and the greater and lesser palatine foramen. So when we look at the axial image, here's the hard palate that's located here. And then on the sagittal images, this is the hard palate. And this just happens to have a tumor that's eroding the hard palate. So hopefully I answered that question.
Yeah. Dr. Mukherjee, I'm gonna read you. We've got a bunch in the Q&A box, so I'll go ahead and read those out to you, and then we can pop over to the chat. So
Okay. You do your thing. I'll
there's
just
a
tell you, I'll just answer what you did to me, okay?
awesome. Okay, what sagittal views can we use to see better the oral tongue and calculate the depth of invasion?
So again, you're sort of talking about the depth of invasion. I'm going to plead uh, at this point in time, try not to do that. I'm gonna suggest that if you want to measure the tumor thickness, then what I would suggest doing is to look at whatever orthogonal view will give you the best location to go from the surface to the depth. And like I said, I do not measure the lateral thickness at all, unless they ask me to. What I do mention, so for instance, I don't know if you can see my screen here, Ashley. Can you see the
Mm-hmm.
screen right here? So what
Yep.
I do here is that I will measure the largest measurement that I can get because that factors specifically into the AJCC. But when I talk about this thickness right here, I would go from my arrow here to out here and just say that if they want to, I'll just say this tumor thickness is about what, a centimeter and a half or 2 centimeters. But the main thing is whether or not it crosses midline. Because in the situation like this, oral tongue cancers are likely going to be non-HPV positive. So for instance, in the image here on the middle image, I would go ahead and mention this cross-sectional thickness, but what they really want to know is what's the relationship to midline. So you can comment on tumor thickness if you want to, but from a macroscopic perspective, because it's not HPV positive, these are usually HPV negative. They're usually treated with surgery. The margin has to be about a centimeter, oncologic margin of a centimeter. So what's really important, at least from my experience, is how close does this tumor get to the midline, and also how deep does the tumor get? So in this particular case, the wideness here goes to right about the midline. So in order to get the oncologic margin, they'll have to come here. But more importantly, it's not necessarily trying to guess the depth of invasion, but look how inferiorly this tumor gets. Look at my tiger stripes on the left-hand side. See all of this area right here. This is the most important thing because oftentimes surgeons underestimate that inferior depth. And if they don't get it all the way down here, they're going to end up having a positive margin. And for me, that's the most important thing to measure when you're looking at tumors. It's not necessarily the depth of invasion, but macroscopically, what does a surgeon have to resect in order to get a gross tumor resection and have negative margins? Sorry for the long reply.
No, it was great. You actually had a couple questions on that. So, yeah, you answered a couple at once. For our next one, how do you differentiate between vascular tumor like hemangioma, excuse me, or venophatic malformation involving the glandular gland, which is more common.
Yeah, so that's a great question. Honestly, that's a talk into itself. I have a 45-minute talk on a simplified approach to vascular malformations. So if you guys ever want me to give that, Ashley, I can give it to you. What I can say really briefly is that there's a lot of confusion about the nomenclature. Hemangiomas are distinct entities from vascular malformations. Hemangiomas are characterized by endothelial proliferation that can be hypervascular, and they're oftentimes associated with a surrounding soft tissue mass. A veno-lymphatic malformation is a does not have endothelial proliferation, and the veno-lymphatic malformations typically involve a muscle. They typically have phlebolytes, and they do not have the flow voids that we see in the proliferative phase of a hemangioma. So they do not have a necessarily a surrounding soft tissue mass. Rather, they oftentimes have fluid-containing structures that are more characteristic of a veno-lymphatic malformation. So I really can't get into that too much more, but I can give a future talk on that if you want.
Yeah, for sure. Okay, can the marrow be infiltrated with evident cortical destruction on CT?
Yes, it can be. So I think a lot of it depends on your technique. I would say that the likelihood of having tumor involving the marrow without cortical erosion on a very, very good quality CT is very rare. But if you are looking at your assessing your CT scans with thick sections and bone windows, then there's a high likelihood that your resolution on your CT scan may not be sufficient to look for that cortical erosion. I would say that if you have a very, very thin section CT and the cortex is intact, then the likelihood that you have tumor in the marrow is rare. Now, having said that, um, you can have, and I have seen this before, is that you can have a completely intact cortex, but the marrow is replaced. Now, all squamous cell carcinomas have a very robust peritumoral inflammation. So when you look at the marrow, sometimes what ends up happening is that you have marrow replacement, and that's all inflammation. And then the question comes up, is that inflammation just benign inflammation or is it tumor? And we really can't tell. I can give you my impression is that if I look at a GBM, a brain GBM, and I see vasogenic edema, it's been shown that that vasogenic edema contains choline. So which means there are tumor cells surrounding in that edema surrounding the brain tumors. So my opinion is that if I have a reasonably sized carcinoma that's adjacent to the bone and I see replacement of the marrow, I'm concerned that even if it is inflammation, I'm concerned that there is microscopic disease within that inflammation. And that's just my opinion. And I always convey that to our surgeons. In general, if I say the marrow is replaced, then they're probably going to do an extended mandibulectomy.
Awesome explanation. There's a clarification question. Did you say perineural spread and perineural invasion are not the same?
That's correct. Perineural invasion. In fact, I think you can see my slide, right?
Yes.
Yeah, perineural invasion is a microscopic diagnosis where the pathologist looks at the tumor and sees small little nerve fibrils that are completely invaded or involved with tumor. Perineural spread, and I'll see if I can get to this. Perineural spread is a macroscopic diagnosis where can you see my screen, Ashley? We can
Yep.
actually see the tumor itself that is involving and enhancing the nerve and oftentimes enlarging it. So perineural invasion and perineural spread are two distinct entities.
And any tips for evaluating perineural spread?
Yeah, so MR right here. So what you want to do in order to evaluate perineural spread is that you want to do thin section images. You want to give contrast. And what you do is you look for abnormal enhancement. And oftentimes when it's more advanced, you can see involvement of the nerve. So for instance, when I look at this image right here, here's the normal nerve right here, and there's the vascular plexus. This is the same nerve on the opposite side, and notice how there's abnormal enhancement and enlargement of that nerve going through. In this case, it happens to be foramen rotundum.
Okay, gotcha. Why is it important to distinguish between primary tumor of the lip from those of buccal mucosa?
Of the buccal mucosa.
Mm-hmm.
So, um, yeah, so that's a good question. So I mean, it's really hard on imaging to separate out a lip cancer. Let me put it this way. A lip cancer just involves the lip. The buccal mucosa is when the tumor creeps on the backside of the lip and actually starts extending into the oral cavity. So if it's on the outside of the lip and there's no deep extension, then the surgeons can potentially just chop it off or do a small little skin graft. But once it actually extends on the back surface of the lip, then oftentimes the surgeons are going to have to take that whole lip out. But in general, from an imaging standpoint, it really is hard to determine the full extent of lip lesions. The most important thing is to try to identify whether that tumor that's involved in the lip extends deeply into the gingiva buccal sulcus, and also whether it involves the gingiva overlying the mandible and the maxilla. That's what we can do on imaging if we do that puff cheek technique. But remember, that area can also be seen on clinical examination as well. So we want to make sure there's no large submucosal extension of the tumor.
Gotcha. Do you recommend a specific time of acquisition after contrast for detection of head and neck cancers?
Yeah, we do. What I like to do is give you a historic perspective. In the old days, we would just give contrast and then we would acquire the images. But then what ended up happening is that with multi-detector CT, if you give the contrast and just image, basically everyone's getting a CT angiography because we're imaging so fast. So the purpose, I'll leave it this way, is the purpose of giving contrast is twofold. Number one is that you want to make sure that you have opacification of the vessels, and that's both the arteries and the veins, because you want to make sure that you don't want to call an unopacified vein a lymph node. So you want to make sure lymph nodes and vessels are completely separate and you can see the vessels and separate those from the lymph node. So that's number one. The second thing is that if there is enhancement of tumors, if you do have a tumor, tumors can enhance. Now, tumors enhance differently, but what you want to do is when you give contrast, you want to give sufficient time such that the contrast material has enough time to permeate into hypervascular tumors, any type of tumor. So the best way that we like to do is that after multi-detector CT came out, we published this, I think, probably about 15 years ago, 20 years ago, is that we give, if you will, a loading dose of about 50 cc's and we wait 90 seconds. So we wait 90 seconds. And that gives enough time for the contrast to cycle through, if you will, the arterial to venous phase, and also gives it enough time for the contrast to go into tumors. And then what we do is we give another 25 to 50 cc's, and then we image again. And that 25 to 50 cc's just ensures that the contrast is actually in that vascular phase again. So the first half of that loading dose, if you will, is to make sure contrast has enough time to get into tumors. And the second half is to opacify the vessels. And then a lot of this is just fine tuning on your end. What you want to do is have equivalent opacification of the vessel. So, you know, when you give that second dose, you may give more, you may give less, you may have a little bit of a delay, but that's something that you can kind of tweak in your own practice.
Okay, we'll do a couple more here. This is kind of random, but do you have a book you would suggest for a dental student for radiology?
That's a great question. That's a good question. I think I mean there's so many books that are written out. I think you're probably looking for something that's super concise to get you there. Um, I'd have to think about that. I think the books by Elsevier are really good. They have terrific pictures in them, which I think you'll find really, really helpful. Um, they're a little bit hard to read in the sense there's a ton of words in them, so I think it'd take a little bit while, but the images are great. So if you're a visual person, I think that would really be helpful. Otherwise, there are various, for instance, I'm going to just, I think you mentioned that I'm a editor-in-chief for the clinics. So for instance, like in the clinics, we do have short little concise monographs on various topics in all of neuroradiology, and we've done several on the head and neck. So if you want something that's concise, clear and concise, that's focused on a certain topic, I think those are helpful too. If you have specific questions, you can do what I end up doing a lot, which is Googling stuff and try to find out. But I don't know if there's like a 100 or 200 page book that's going to give you everything you need. The other book that's good too is The Requisites by Dave Usum. I think that's a really good book too. I think that's both neuro and head and neck, but I think that head and neck section would be a good start as well too. So those are 3 or 4 options for you.
Awesome. All right. We'll do this one and then call it. How do you differentiate between osteonecrosis of mandible post radiotherapy versus osteomyelitis?
Yeah, that's a great question. So there are a couple things. Number one, again, I'm biased because I see patients. So when I go and see the patients, osteoradionecrosis is actually dramatic to see because depending on how advanced the osteoradionecrosis is, you walk in the room, you can literally see the bone sticking out. And when the patients can literally spit, they can actually take their finger and either spit it out, or the surgeons can go in and take the pliers and take some of the bone out of the mandible. It's pretty dramatic. Now, in full frank osteomyelitis, you could have that aggressive bone erosion and the destruction, but oftentimes there's a lot of soft tissue components surrounding it. So, for instance, when I showed that case of the medication related osteonecrosis, notice I specifically chose this case because there was some soft tissue that I think you can see my screen, right, Ashlyn? Um, you can see that is that right, Ash? You can
Yep.
see it. Okay. So you can see that the masseter muscle is a little bit enlarged, but notice the fat right here. The fat's very clean. If this was a rip-roaring osteomyelitis, you would see inflammation and edema surrounding the soft tissues. So radiographically, this could be either or if I just looked at this, but the fact that this fat is so clean, that suggests that this is more osteonecrosis as opposed to osteomyelitis. Now, having said that, clinically, if they have a patient that does have osteonecrosis that's radiation associated and it's progressive, they'll go ahead and put the patient on antibiotics because oftentimes in radiology, we like to say either or, but in the real world, you can have 2 things happening at a time. So in the real world, if you see something like this, they'll go ahead and put the patient on antibiotics in hopes that if there is an overlying infection that could be exacerbating this, they'll try to cool it down.
Super helpful. Thank you so much. I think we'll end it there. Thank you for answering all those questions and for your amazing lecture. We're doing part 2 on November 14th, the anatomy and pathology of the oropharynx. Did I say that right, Dr. Mukherjee?
Oropharynx. Yeah, you're getting there,
Yeah.
Ashley.
I'm getting,
You'll become a head
I'm
and neck
a
radiologist.
radiologist in training.
You are a head and neck radiologist in training.
Well, thank you again for being here. That was excellent. We really appreciate it. And for everyone else, thank you so much for signing on and asking such amazing questions. We hope we see you November 14th for part 2 of this lecture. Be on the lookout for registration info on that.
All right. Thanks everyone for attending. Ashley and the team, thanks so much. And
Uh,
thanks everyone for taking the time to participate.
Absolutely. Thank you. And everyone else be sure to join us next week on Thursday, October 3rd at 12 p.m. Eastern. Dr. Singhal will deliver a lecture entitled Ultrasound of the Bowel. You can register for that at mronline.com and follow us on social media for updates on future Noon conferences. Thanks again for learning with us and have a great day.
Thank you. Still there, Ash? Or are you still gone?
I'm here. Yeah.
Good work. Thanks a lot. Hope it went
Thank you
well.
so much.
Send me the final numbers.
Yeah, I'll send you an email.
Sounds good. All right. Thanks a lot.